Good afternoon, everyone. And once again, thank you for joining us. Before we begin our webinar, I'd like to say a few introductory remarks about Yetena Weg. Okay, Yetena Weg is registered in Pennsylvania, USA as a non-profit, and it's run entirely by volunteer members. We have more than 70 active volunteer members at the moment, spanning across 5 different countries and counting more by the day. And as you can see from the picture on the right-hand corner, it's a picture showcasing our volunteers at a get-together. So our projects and engagement can be seen in 4 aspects. The first is health promotion, which is done via discussion and articles regarding the health of the general public, health policy and its implementation in our country and globally. Our other engagement is through the community engagement. So it's done by organizing blood drives, inclusivity and equity projects and fundraising campaigns. Our third and strongest project we have is mentorship and skill sharing, which involves direct mentorship, soft skill, career and professional development webinars that are prepared for health professionals. And our last is the medical education project, such as this one, which involves our continued medical education and research and quality improvement projects. So it now is more than a digital platform. It provides a platform where volunteers can come together and make meaningful impacts. Okay, this is a slide showcasing our volunteers across different volunteering activities. As you can see them volunteering in donation campaigns and in inclusivity trainings and in screening projects as well. So our other engagement is done in collaboration with ROHA and IMSA for the Yetena Weg ROHA Health Article Writing Competition. The third round of health writing article competition is organized in collaboration with the Ethiopian Medical Students Association, and it will be announced shortly. ROHA Medical Campus, through its ROHA Health Foundation, will award travel grants for 2 health article writing competition winners. Yetena Weg will award pulse oximeters for the top 20 and Littmann stethoscope for the top 3 winners. And the top 5 winners will also get internship opportunities at ROHA Health and other partner institutions. So as you can see from this image, it's a slide showcasing the 2021 article writing winner getting her prize. And on the right-hand corner is, as you can see from the image, it's a slide showcasing the prizes prepared for the 2022 winner. And this is another slide showcasing the 2023 article writing winners that got the opportunity to travel abroad to the University of Global Health Equity. Our other project is the Yetena Weg ROHA Research Fellowship. So it was done the first wing was done in collaboration with the Kurambasa Specialized Hospital. It started on March 14th, 2023. 3 departments were involved, mainly oncology, radiology, and internal medicine. And research grants were awarded for the top 4 winners after they were announced, and the mentorship was provided for the subsequent 10. The other is done in collaboration with St. Paul Hospital Medical College. What's different on this one is prepared for medical students, mainly medical interns. Research grant has been awarded for 4 winners. The winners have already been announced. As you can see from this slide, these are the research and QA fellowship winners from the Kurambasa Specialized Hospital. They're all residents, 2 residents from internal medicine, a single resident from oncology, and another from radiology. And the Yetena Weg Research and QA fellowship winners from St. Paul Hospital Medical College. 4 interns at the time were chosen. So when we come to our CME sessions, it's freely accessible, and Yetena Weg partners with the Ethiopian Medical Association, the Ethiopian Society of Cardiac Professionals, the Ethiopian Society of Internal Medicine to provide continued training for healthcare professionals. We've had 20 CME webinars held so far for the year 2024. We invite renowned both local and international speakers, and our average webinar attendee spans from 150 to 200 healthcare professionals. So for 2024, we've planned to hold more than 30 webinars focusing on emergency, surgical, and medical cases, ENT, pediatrics, OBGYN, and more. So you can access our previous CME sessions by going to our YouTube channel. And you can also get updates about our upcoming CME sessions by joining Yetena Weg's Telegram channel for healthcare professionals and by following our social media posts. The links will be shortly posted in the chat box. And in order to get the best experience in the webinar, we ask that you send your questions to the Q&A or to the chat box. And at the end of the webinar, your questions will be addressed by the guest speaker accordingly. And to get CU certificates, you must fulfill the following set of criteria. The first is attend the whole session virtually, because the minutes attended will be checked by the Zoom attendee reports. The second is to fill the Google form for personal details and attendance. Make sure the credentials you provide are correct, and you must be able to score 50% and above on the post-webinar quiz. So you'll be able to see your results right away, but the process of issuing certificates will take up to 2 weeks to be delivered to your email. So in the meantime, we ask that you wait patiently, and the post-CME quiz link will also be posted in the chat box, and a dedicated Telegram channel or group has been created. So we urge everyone to join that Telegram group to be able to access the link. So thank you. So having said that, as I've tried to say during our introduction, our webinar today is with Dr. Fekede Agwar, and the topic is who will benefit from valve surgery in rheumatic heart disease. So before we start, I would like to introduce our guest speaker for today. Our guest speaker today is none other than Dr. Fekede Agwar. So Dr. Fekede is a pioneering cardiac surgeon. He holds a medical doctorate from Gondar College of Medical Sciences, a specialty training in general surgery from Addis Ababa University, and a subspecialty training in adult and pediatrics cardiac surgery from Narayana Institute of Cardiac Sciences in India. Dr. Fekede has made significant contributions to cardiac surgery in Ethiopia, including performing Ethiopia's first successful open heart surgery in 2017 by leading a fully local team, the first successful Bentall procedure, coronary artery bypass graft, and complex valve surgeries with over 700 heart surgeries to date. He has served as a lecturer and assistant professor at Hawassa University and currently works as a cardiac surgeon at the Cardiac Center of Ethiopia. Dr. Fekede is the founder and board chairman of Healing Valves Ethiopia, an NGO that is dedicated to providing life-saving heart surgeries to underprivileged patients. He has authored several research publications and books, including the critically acclaimed Memoir of the Heart Surgeon, and has received awards such as EMA's Merit Award and the 2021 Rising Star Award. Dr. Fekede is a regional governing counselor for the East African Pediatric and Congenital Heart Surgery and is also an active member of several professional societies, including the World Society for Pediatrics and Congenital Surgery. Okay, without further ado, I would like to introduce our guest speaker, Dr. Fekede. I'll share my screen and Dr. Fekede can proceed.
Thank you. Thank you very much for the kind introduction. And first of all, I would like to say a few words about this program. I think these kind of initiatives are very important, especially for the kind of topics that we are going to talk, which is rheumatic heart disease. And I believe that it is one of the areas where sensitizing the community and teaching the community is better than doing the surgery or the treatment, because rheumatic heart disease can be completely eradicated by raising awareness in the society. As you know, this disease is becoming a history for the affluent societies, and it's only a huge burden for the developing countries. Having said that, I'm thankful for the Cardiac Society of Ethiopia and the Yetena Weg committee for giving me the chance for this talk. And my topic will be the management of this chronic severe rheumatic heart disease surgically. Next, please. These are the outline of the topics that I'm going to talk. Next, please. Next. I don't have any disclosure to make. Next. So, as you might know, this rheumatic heart disease is simply eradicable and preventable disease. But unfortunately, it is not the case in our situation, especially for sub-Saharan African countries. It is one of the huge burden for of cardiovascular disease, and as you know, more than 300 to 400,000 people die each year, especially in developing countries, especially in sub-Saharan African countries, with an incidence rate of 2.5 to 3 points per 1,000 people. Approximately 1 to 5% of these people with chronic rheumatic heart disease die each year, and of this mortality, is more than 95% of them occur in our situations with low-income countries. So for those patients with end-stage chronic rheumatic heart disease, surgery is the mainstay of treatment. So what is the time and who benefits from this surgery will be the topic for today. We will not talk about the pathophysiology and the risk factor and so on and so. We'll just go for those patients who have been already labeled or diagnosed as chronic rheumatic heart disease, be it for mitral, aortic, or multivalvular lesion. So we'll talk about which patients might better benefit from surgery. As you know, some of the patients, especially with critical or severe MS, might be subjected for percutaneous balloon valvotomy, but there are situations where balloon valvotomy may not be advised. Like, for example, in situations where there is huge burden of clot and the medical treatment cannot reduce this clot burden in the left atrium or in the left atrial appendage. Please next. So when the valve is severely damaged, especially the situations that we are seeing in our situation, in the mitral position, you can see patients with high Wilkins score, with the leaflets thickened hugely, subvalvular apparatus shortened, the papillary muscle shortened, and all of them, the leaflet, the papillary, the chordae, and the papillary muscles are bunched together. So in those conditions, patients will not benefit from percutaneous balloon valvotomy, especially in the situations where there is a mixed stenotic and regurgitation lesion. Usually, surgery is the best management. When there is a concomitant valvular lesion, especially aortic and tricuspid lesion, this is also one of the clear indications of surgery. I want to talk one thing in clear that we are not talking about the indications in our country, because in our country, the service and the accessibility for cardiac surgery is very meager for patients who have, this is a huge burden, be it in the pediatrics or in the adult. In our country, the largest burden, be it in the OPD visits, patients who have been admitted to the ward with congestive heart failure, be it those patients who are staying in the ICU, all of them are because of rheumatic heart disease. And the leading cause of all this burden is because of rheumatic heart disease. So having said that, we don't have the access for surgery for all those patients, and sometimes patients might be attributed or subjected for balloon valvotomy, but that doesn't mean that that is a clear indication, but it gives some relief for some of our patients. So patients with NEAC classification 3 or 4, and some selected patients with even class 2 with severe valvular lesions, still we recommend surgery is the best treatment. As I have said previously, in some situations, especially in severe mitral regurgitation, even if patients are asymptomatic, if there is a decrement in the ejection fraction, that is the time to go for surgery. Next, please. So sometimes by the features that we see on the echocardiography, anatomic and physiological features, when you say anatomic features, the the apparatus that we see are the annulus, the leaflet, the chordae, and the papillary muscles. All these muscles, all these apparatus should be closely scrutinized, and if these apparatus are severely fused, heavily damaged, surgery is a mainstay of treatment. When we say physiologic, we mean that the severity of the stenosis and the regurgitation for mitral and aortic. So in case of severe stenotic and severe aortic regurgitation or stenotic lesion, still surgery is a mainstay of treatment. Sometimes T is the best option than the transthoracic echocardiography, especially in the situations where you want to see thrombus closely, or sometimes if you want to see vegetations closely in the aortic and the mitral position, you need to have the probe closer to the heart, and that is transesophageal echocardiography. Next, please. So, as you know, more than 80% of our patients present with mitral stenosis, And the time to consider mitral valve stenosis and to consider for surgeries, as I've said it previously, when patients have severely anatomically distorted or destroyed valves, when at this time you will not hear the opening snap because the valve is already heavily fused, the leaflets are calcified, the cordae are fused, and the papillary muscles are not moving. So in this case, severe subvalvular disease and associated especially along with mitral valve stenosis when there is a regurgitation, surgery is the best option. So more symptomatic, like patients with chronic valvular heart disease with repeated admission to hospital by chronic congestive cardiac failure, those patients are best managed by surgical intervention. Next, please. Usually, the mitral stenosis by itself will give us evidence, enough evidence for the decision making, but sometimes we have to pay attention when it is mitral valve regurgitation, because during mitral valve regurgitation, the functional status of the left ventricle really is very important to have a very good outcome in postoperative period, to have all the possible outcomes and to discuss with the families. You should always assess the LV function for what could happen in the postoperative period. Next, please. So sometimes in severe mitral valve regurgitation, patients might not be symptomatic, but the functional status of the left ventricle is very important factor. When the left ventricle function is starting to decline below 60%, irrespective of the patient's functional status, it is better to go for surgery. So apart from the anatomy, the function, and the clinical status of the patients, sometimes patients might present in our situation with infective endocarditis or stroke. So it is not uncommon to see our cardiac patients with rheumatic heart disease with presenting with stroke. So what is the timing for those patients with chronic rheumatic valvular heart disease presenting with a stroke? So in such situation, it's always good at least to wait for 6 weeks, because data are showing that those patients who underwent surgery before 6 weeks presenting with a stroke are highly likely of ending up with another stroke in postoperative time. So the data are suggesting that it is better to take at least 6 weeks for patients who present to us with a stroke. With regard to infective endocarditis, sometimes our patients, as you know, patients with chronic rheumatic valvular heart disease, the anatomy of the valve is destroyed. So such kinds of valves are vulnerable for infection. So it is common to see our patients sometimes presenting with infective endocarditis features and in congestive cardiac failure. There is no real consensus time as to when to take such patients when they present with acute infective endocarditis, but generally the clinical situation of the patient will guide us to when to take these patients. So if the symptoms are mild or moderate, sometimes it's better to control the infection for some 2 to 3 weeks and then to go for surgery. But if patient's hemodynamic status is deteriorating rapidly with deranged renal and end organ function, it is good to take an urgent and emergency decision by taking patients to the surgery. Sometimes patients might even end up with systemic embolization like stroke or peripheral stroke. It's not uncommon in our setup to see patients being amputated for chronic rheumatic valvular heart disease. I have a lot of stories with these chronic rheumatic valvular heart disease patients ending up with amputation before they have surgery. So in such situations, it is better always to take surgery when, especially in case of infective endocarditis. Next, please. So another situation that's common in our setup or in every chronic rheumatic valvular heart disease, patients might present during pregnancy, especially patients with severe mitral valve stenosis. So in such conditions, it is one of the challenging areas to take what decision to take. So in such conditions, as you know, that patients with such kind of presentations are highly they are susceptible for prematurity, IUGR, and there are associated morbidities associated with this. The best option is always trying the best of your capacity to postpone the surgery and not to do the surgery during pregnancy, unless catastrophic situations are obliging the surgeon to take for an emergent and urgent situation. It's always better to defer the surgery during pregnancy. If at all patients, if it is only mitral valve stenosis, it's better always to take option of percutaneous valve. But when it comes to surgery, the best option is always to avoid it during pregnancy. But if situations are really going critical, you might take a decision in the second trimester, after second trimester, where you can take both decisions, both cardiac surgery and at the same time you do cesarean section and deliver the baby in the same surgery. Continue, please, next. The other situation is patients who present with mixed lesion, that means both stenotic and regurgitant. This is common in mitral position. And in this condition, it's not only that the decision is only, the decision should be surgery, but the decision should also be, it should be replacement, because those patients who have mixed stenotic and regurgitant lesions usually will not benefit in the long term by valve repair, especially in the mitral position, because the outcome will not be long lasting, because that tells you that the lesion being mixed stenotic and regurgitant, it tells you that the apparatus, the annulus, the leaflet, the chordae, and the papillary muscles are heavily affected. And by repair, you may not achieve the desired outcome, especially in the long term. So whenever you have a mixed lesion, the option is surgery, yes, but it should be also one step further that the option should be surgery, and the option should be valve replacement, not repair. Next, please. The other is aortic lesion. As you know, that isolated aortic lesion is not that much common with rheumatic heart disease. Usually, when you have an isolated aortic lesion, you have to look for some either congenital or degenerative process. But the literature says it is 10% of rheumatic heart disease present with an isolated aortic lesion. But if you ask me my personal experience, in my very limited short experience, it is even 1 to 2% of my surgeries are isolated aortic valve lesion for rheumatic heart disease. So in such conditions, the option in aortic valve lesion, the option should be straightforward replacement, especially in our setup, because and whatever expertise hand aortic valve repair usually doesn't last long. And you know that the chance of cardiac surgery in limited resource setup like ours is a lifetime chance because of its availability, cost issue, and everything. You cannot give the chance for such poor patients, such poor situation with a short-lasting solution. Next, please. So this video shows you that one of the classic situations where aortic valve is isolatedly affected by rheumatic process, and it is not really common. As I have told you, it is only for example, in my surgery, it is only in 1 to 2% of the cases that you get isolated aortic rheumatic process. Next, please. Usually, patients with chronic rheumatic heart disease, there is usually the disability like stroke, because most of our patients might have stroke with right hemiparetic history or left hemiparetic or speech delay, speech or something and so on. These are not really contraindication for surgery. And as I have told you that there are multiple lesions can be there, but still none of them are contraindication. associated coronary artery disease or associated Agwar lesions are not also a contraindication, and severe pulmonary hypertension has never been a contraindication for surgery in this situation. Next, please. This is just the approach for aortic valve approach for rheumatic heart disease. As you see, all the three leaflets are thickened, fused, and this is how we approach the incision into the non-coronary cusp, and we cut out the three cusps and put a prostatic valve. Next, please. With regard to mitral, you can have 3-4 options. Either it can be the most common option and the most reliable. You can have a good access is through the Sondergaard roof, through the left atrium. But sometimes if you have to do surgery on the right side, like tricuspid valve repair, it is better to approach through the right atrium, through the interatrial septum. Robust approach is there when you have a very small left atrium, when you have an acute hemorrhage, and sometimes in emergency situation, you can approach transdome or superior approach. Next, please. So there are different surgery for rheumatic process. As you might know from history, there used to be a closed mitral valvotomy, CMV. Back in the past, like in the 1950s, 1960s, where heart surgery were not developed, people used to do thoracotomy, put their fingers in the left ventricle apex, and a kind of wire through the left atrial appendage, and you will approach your fingers in that wire in the mitral valve, and you just broke the fused mitral valve. But this is totally obsolete nowadays because this option can be easily supplied by balloon valvotomy. And in settings where you don't have balloon valvotomy, you can even do open mitral valvotomy. But if the valve is severely damaged, even open mitral valvotomy is not advised, because if you have the option of valve replacement, it's better to go for mitral valve repair or replacement. So the options, there are a lot of options like open mitral valvotomy, combined surgeries like open mitral valvotomy with AVR, mitral valve repair with mitral valve replacement. Sometimes if you have a good mitral valve apparatus, the apparatus that we have talked before, the annulus, the leaflet, the chordae, and the papillary apparatus, if they are good enough for repair, it is better to repair mitral and replace the aortic valve. The teaching says like that because one thing, the target INR will be low, and the other thing, the outcome is almost, the long-term outcome is said to be comparable with that of the double valve replacement. And sometimes you might have the option of double valve replacement plus tricuspid valve repair if all the valves have been damaged. And there are also associated procedures, like sometimes we do maze procedures for the atrial fibrillation. If you think that patient is young and you don't want to put mechanical valve, if you are going to do valve repair and or tissue valve replacement for those patients for whom you don't want to put mechanical valve for different reasons, especially for young reproductive age girls, for whom you don't want to give them warfarin, sometimes you might take the option. With regard to this topic, you might raise questions at the end of the session. We can discuss a lot. LA clot removal, LA appendage excisions are important adjunct for valve surgery, and left atrial reductions are some of the adjunct valve surgeries. Next, please. So this is the one that I have discussed already before. Next, please. So this is how they used to do the closed mitral valvotomy, which is nowadays obsolete totally. Next, please. So as I have told you before, one thing should be clear. Sometimes you shouldn't treat the books. You have to treat your patient, your people, and your society. So in most of the time nowadays, the debate looks to be settled that it is always better to go for mitral valve repair in cases where you find good valve apparatus. But as I've said it before, you have to analyze not only the patient, but your society. if you know that your patients are having one lifetime chance for valve surgery, heart surgery, you know that heart surgery is expensive, but when it comes to valve surgery, it is more expensive. The reason is valve, the valve that we are replacing, or even for repair, the rings that we are using are the most expensive consumables in cardiac surgery. The most expensive consumables in cardiac surgeries are valve or the ring. Okay, so when it comes to valve surgery, the cost is very huge. You know that it's almost near to $1 million Ethiopian for heart surgery, but when it comes to valve surgery, it is even more expensive. Sometimes your patients might have multiple valve surgeries, so that will make it even more expensive. So what I'm telling you is that sometimes we don't treat our patients, we treat the society, because you have to analyze the situation and you have to give a lifelong, one long-lasting solution. Like that's why most of the time we go for replacement, because it gives you a long-term better outcomes than repair. For one thing, most of our patients comes at far advanced stage, which means they will have a mixed lesion. They will not have an isolated. It is uncommon to see in our situation an isolated stenosis or an isolated regurgitant lesion. Most of our patients have a mixed lesion, and that means the valve is badly affected. So those patients might not benefit better from repair surgery. But still, in a selected situation, like in young age, especially in less than 10 years or even up to 14 years, you might get a pure mitral valve regurgitation with dilated annulus without any stenotic lesion. In that situation, especially in pediatric age groups, a repair might benefit better for the patients. So you shouldn't only taken away by the books that are written from the Western. As I have told you, it is nowadays it's not their problem. They are only dealing to find a vaccination for rheumatic process. The world is now, the Westerns have shifted their direction for rheumatic process to get a vaccine. Now the whole attention on rheumatic and the research is totally funded for the getting a vaccine. So as you know, it is not their problem, and they are trying to get a vaccine. They are not dealing with the surgery. It is in our situations that we are dealing in our day-to-day life, a valve surgery. You know that today, this morning, I came to this session after I did a valve replacement surgery for a 27-year-old female from Ambo. And you know what? She was followed by a cardiologist. He was giving her warfarin for a very long period of time. She was having severe MS, mild MR, but there was huge clot in the left atrium. But despite a continuous warfarin treatment, the thrombus or the clot was not going. And we did the surgery today. When we opened the left atrium was full of clot. And I was telling my assistant that sometimes mitral stenosis is a lifesaver. You know why? Because this patient would have died, or she would have come with a massive stroke had it not been for the severe MS. Because the severe MS, she has a pinpoint injury. The severe MS has saved this patient's life. The clot cannot go into the left ventricle, and the MS has saved the patient. So we just did all the clot removal from the LA appendage exclusion, and mitral valve replacement was done. So I'm just giving you an example that you should always analyze the situations that you are in. Next, please. So this statement is not with rheumatic process, okay? So most of the patients for the Western or for the books that we are reading, they are writing mitral valve repair is a best solution, not for rheumatic, but it is for prolapse. That is usually a degenerative or connective tissue disease, okay? So, but one thing we have to understand is that mitral valve repair has a very good sides. The post-op course is always smooth if you have a very good valve repair and you have a safety, you have the chance to sleep nice for sending patients to remote area, because they may not need lifelong warfarin, they may not need intense monthly INR follow-up. So this is the strong side of valve repair because they don't end up with warfarin. Next slide, please. So this is how I do mitral valve repair, as I have told you, only in selected patients. When I think that they will benefit from mitral valve repair, I usually, what I do is I mobilize the chordae in the papillary muscle and augment the posterior mitral leaflet from edge to edge, from commissure to commissure, and put a kind of annuloplasty ring with either glutaraldehyde treated pericardium, or it can be with Gore-Tex patch. Next, please. I think this picture is not showing you nicely, but it was after repair has been finished, when I do saline test, that there was a nice fish mouth, nice smiling type of mitral valve. So it is not shown nicely here. Next, please. Most of the time, patients with mitral valve left side surgery present with tricuspid valve regurgitation, and you have to understand whether the lesion is organic or functional. I mean, when you say organic, whether the valve is affected by the active rheumatic process. In such condition, usually they will present with stenosis of tricuspid valve. But when it is regurgitant only, you have to be cautious that whether we need the surgery for the tricuspid valve or not. It should be the assessment of this, the cardiologist and the surgeon, especially intraoperatively by watching at the right atrium size. The opening of the tricuspid valve annulus is very important. It gives you a good glimpse as to touch the tricuspid valve or not. Next, please. When there is a coexisting tricuspid valve lesion associated with left side valve problem, be it from mitral or aortic, most of the time it is mitral. The chance of the disease to progress is like those patients who have persistent or recurrent mitral disease, RV dysfunction, and if the tricuspid valve is organic one, usually whatever you do in the tricuspid valve, it will progress. Next, please. So when patients undergo tricuspid valve annuloplasty or replacement, usually the post-op course is not as you might expect. It is poor and the long-term survival is low. So this is how I do tricuspid valve repair. And usually when I do tricuspid valve repair, I don't use customized ring. The reason, one of the most important reasons is it incurs additional costs to the patient. I know that it has some slight superiority to that of the autologous pericardium. What you are seeing in this image is that I am using only patients on autologous pericardium. And I just put it there, and the outcome is really nice and good. And this really decreases the costs that the hospitals are giving them to the patients. So this helps a lot for a significant number of our patients. This is, I mean, when you do valve replacement on the left side and valve repair for the right side. Double valve surgery is one of our common surgeries that we do, and that means when we say double valve surgery, we mean mitral and aortic valve, okay? So in 20% of the cases, our patients are affected both mitral and aortic. And when the aorta is affected moderately and above, it is better to address both valves during the same surgery. Next, please. The outcome, by the way, the outcome for double valve surgery is almost the same as single valve surgery. But as you have seen, there are wide variability of reports from 2.5% like that of single valve surgery up to 90%. But the agreement should be the outcome is the same as single valve surgery unless there is an experience issues. So this is what I can tell you, even in our setup, the outcome is the same as single valve surgery. The next important issue when it comes to rheumatic heart disease as to the choice of valve type, which type of valve shall we use for our patients? So usually there is no debate with regard to this topic unless there is an availability issue. So the core point is the considerations is patient's age and the concomitant situation the patient is having. So the most important thing that you need to understand is that sometimes if a patient is young and if a patient is female and want to conceive, you may give the chance that the chance of taking warfarin after tissue valve replacement is only after 6 months. You will stop warfarin and patient continuing on aspirin. So this is the type of discussion that you will have for young, newly married, reproductive active age group. For these groups, you will give them the chance that whether the valve needs replacement, agreed, okay, but shall I give you mechanical or tissue? Then you will give the chance that if the tissue valve will degenerate in a certain period of time, especially when it is in young, especially in menstruating ladies, the chance of degeneration might be very fast. But you have to believe that the current most updated tissue valves, their chance of degenerations are very low, and they stand actively for more than 10 years. So you'll give them the chance that if mechanical valve is replaced, there is no room for discussion that warfarin will be lifelong. The anticoagulant warfarin will be there for lifelong. There will be a change in lifestyle, like you cannot eat high vitamin K containing foods like green vegetables, and there should be an active, at least monthly INR follow-up should be there. This is a type of difficult decision. And you know that there is a situation in pregnancy and those patients who are taking warfarin, especially when it is more than 5 milligrams. So you will give the option to the woman, and the woman will take the decision. So this is one important area of discussion. Another important area of discussion will be if the patient has atrial fibrillation at the same time doing valve surgery, we are going to replace it. And if you are not going to do maze procedure for atrial fibrillation, and if you are going to do mitral valve replacement, and it is always advisable to give them the chance of mechanical valve, because mechanical valve, anyways, you are going to end up with warfarin. And for atrial fibrillation also, we are going to give them warfarin, because patients with atrial fibrillations need to have warfarin because there is a chance of blood clot in the left atrium. So for that matter, patients are anyways going to take warfarin, so better to give them the chance of mechanical valve. The next age group that needs discussion when it comes to mechanical versus tissue valve will be those patients above 65 years old. So when patients are 65 and above, you should tell them that the likelihood of having stroke will be high for those taking this anticoagulant, oral anticoagulant vitamin K drugs, anti-vitamin K drugs. So these patients, this is one important area. They have a high chance of having stroke. The second thing is that the lifetime, what is the lifespan of that country for patients, for people above 65 years. So tissue valves usually will stay more than 10 or 14 years. But when it comes to older people, because they are not metabolically active, there is no high tissue turnover, there is no calcium metabolism actively in the bone, there is no bone turnover in these age groups. So the chance of tissue valve degeneration is very low for these patient groups. Therefore, the valve can stay for long. If the lifespan for that country above 65 years is like, for example, if it is 10 to 15 or 20 years, then it is logical to give them the chance of taking tissue valve only as compared to mechanical valve. So this is the logic. The other side of the discussion will be cost. Tissue valve is more expensive than mechanical valve, true. Second, tissue valve doesn't have sound. So mechanical valve will always have sound that will disturb the patient, that's true. So these are the kind of minor discussions that we have when it comes to choosing mechanical or tissue valve. Next, please. So with regard to this thing, I have already discussed it. So next, please. So one of the most important areas that I need to stress out is that, as you know, it is not a long history for our country, patients having cardiac surgery, be it abroad or in our country, you know that missionaries used to do surgeries in this country. So it's not uncommon to see patients having either tissue valve or mechanical valve for more than 10 years. So it is common to see that patients having those valves which has been replaced, either degenerated or thrombosed or punished or active close, closing the valves. So it is common to see nowadays our patients who needs redo surgeries. Most of the patients cannot afford for the private setup and they are waiting in the cardiac center or in some other government hospitals having severe valvular lesions, which has been done like a decade ago. If it was tissue, it has degenerated and you can see severe transmitral valve gradient. And it is common also to those patients with mechanical valves having punis growing into the leaflets and obstructing. So redo mitral valve surgery is really a life-saving, and the outcome is almost the same as nowadays as that of the single valve virgin or first surgery, but you have to know that it is always high risk because of the exsanguinating bleeding that you might have through the redo sternotomy. So this is a tissue valve that you have seen, which has served for 17 years, for whom I have done the redo surgery some 1 or 2 years ago. Her tissue valve has been done in RHD hospital while the mission used to come. And it is one of the longest serving tissue valves. It has served 17 years, and we replaced this valve with a new mechanical. Next, please. This is also one of the mechanical valve which served more than 10 years, and it has been blocked by an ingrowing punis, as you have seen. This is after I take out the mechanical valve. So patients you might see in your day-to-day activity in the hospital, in your respective working areas, that patients having valve surgery can come with such kind of presentations. So it is really doable in our setups that we can deliver the service. Next, please. So when it comes to mechanical valve, the valve has really evolved a lot. This was the first valve which was being used in the 1960s. It was called the ball and cage. Sometimes you will see patients who have been operated 30, 40 years with ball and cage valve, and it's working nicely. It was one of the valves in the history of cardiac surgery. Then after the ball and cage valve, what comes with the tilting or a single disc valve? It is said to be highly thrombogenic, and it is almost nowadays out of market, but still you will see it in India. It's called Chitra valve in India. Still a significant number of hospitals use such kind of single tilting valve in some of the Indian hospitals. But this valve is almost obsolete because of its highly thrombogenicity. Next slide, please. This is the leaflet or the type of bileaflet disc valve, exactly like the natural valve, where you have, like, for example, in the mitral, you have the anterior mitral leaflet and the posterior mitral leaflet, and this leaflet coaxes, and they have a central lip, which is designed in such a way that it washes away the posterior or the backside of the valve, so that thrombus will not form. So this is the bileaflet disc valve with the commonest nowadays being used. You might have a different brands like St. Jude, Carbomedics, or Medtronic, whatever, and Onyx, whatever, but all of them are bileaflet mechanical valves. So this is the type of valve nowadays being widely used, which serves as the original or the natural valve. Next, please. So this is a tissue valve. Tissue valve is, as I have told you, it is designed from porcine or bovine, from the pericardium of bovine, but when it comes to porcine, it is directly from the heart of the porcine that is taken, and it is formed into 3 leaflets and mounted on this housing, and it will come like a valve. So these valves usually needs some 3 to 6 months coverage with warfarin, because it needs the natural immune cells to cover this foreign body with our own body cells. Then after that, you don't need to take warfarin as a blood thinner because the tissue valve is not thrombogenic. But when it comes to mechanical valve, because it is a metallic substance, it is thrombogenic. It easily forms thrombus. So that's why we need to take warfarin for life after mechanical valve replacement. But in case of tissue valve, unless the patient has some other issue like atrial fibrillation, which needs warfarin for prevention of stroke, they don't need warfarin for lifelong. Next slide, please. So as I've told you, mitral valve repair, if you have a good outcome, the mortality in the hospital is the least one. So it has a very good outcome, be it for rheumatic or whatever myxomatous lesion, the outcome is very good. Next slide, please. So as I've told you, the technique that is used for rheumatic process is totally different from the myxomatous or for the degenerative lesions that's being common for the Western side. But when it comes to rheumatic process, mitral valve repair has different components. I think this is the details of surgery. We don't need to go through this one. Next slide, please. So hospital mortality and long-term outcome is very good for mitral valve replacement. It is said to be less than 2% nowadays. Next slide, please. So this is what I do most of the time and what I encounter day-to-day of my surgery. As I have told you, more than 50% of my surgeries are rheumatic heart disease, and this is what you see. The one that you see, the thrombus in the left atrium or in the left atrial appendage. And what I do is always valve sparing mitral valve replacement. What you see in the other one is I take out the anterior mitral leaflet until the papillary muscle, and I leave most of the time, almost always, unless it is heavily and hugely calcified mitral valve where I cannot really take out the anterior mitral leaflet only with heavy calcification. And I cannot able to decalcify sometimes. And in that situation, I will take out all the anterior mitral leaflet and posterior mitral leaflet. But in this case, you can see that only the anterior mitral leaflet is taken out. And that's what I do in more than 99% of my surgery, where I do mitral valve sparing mitral valve replacement. This is very important concept because keeping the annulo-ventricular continuity is one of the core thing in having a good outcome during postoperative time. So if you keep a good amount of annulo-ventricular continuity, the ventricular function will be good during postoperative time, and new patient will do good throughout the course. Next slide, please. So this is how we do mitral valve replacement. You can see just in one of my surgery where all the stitches have been put in one of, it looks like a paramedics valve. So the valve is almost to be seated on the mitral position. Next slide, please. So as I have told you, the long-term and the short-term outcome for mitral valve is very good, and the decision should be based on the patient, based on the situation that you are in. When we say conventional and valve sparing, the conventional valve replacement means you just chop out everything and you put valve. And when we say valve sparing, we mean that sparing at least the posterior mitral leaflet and keeping the annular mitral continuity. So that's called valve sparing valve replacement. Next slide, please. So this is after valve surgery, there are a lot of complications. I just want to talk about some of the complications because we live with these people, with this life, and it is our day-to-day life, and it is better to be aware of some of the major complications that we face during valve surgery for rheumatic heart disease. So one of the most common complications that you will encounter in after valve surgery is hemorrhagic stroke. Our patients sometimes might come with bleeding. If they are female, sometimes they might have a long menstrual blood flow, which cannot stop after a long period of time. Patients might come with low hemoglobin. Patients might come with nasal bleeding, urethral bleeding. But the most common presentation that you will face in our setup is either hemorrhagic stroke or patients coming with excessive menstrual flow and with severe anemia. You will have a patient to be admitted and need blood transfusion. So this is because of the complication of warfarin and the blood thinners that they are taking for their valve surgery, especially for those with mechanical valve replacements. So the incidence is, as you said, 2.3 to 3.4 per 100 patients per year in those with mechanical prosthesis. So the 5-year, 10-year, and 15 years chance of this anticoagulant-related hemorrhages, as you see, is significant. Next slide, please. The other important complication is thromboembolic complication after valve replacement, because sometimes you might have put a valve in the mitral or in the aortic position, but still you might have severe LV dysfunction. You might have rhythm disturbance like atrial fibrillation or flutter. You have a lot of situations where you can have a clot still in the heart, and this clot can easily escape mainly to the brain and to other end organs, peripheral organs. And there is a chance that 2.2 to 4.4% of our patient might have thromboembolic complication per year. Next slide. So with bioprosthesis, of course, it is lesser as compared to those patients with mechanical valves. So the most important reason for that is that the cause for this thromboembolic complication is most of the time inadequate anticoagulation is the cause for thrombus formation in the heart and subsequently for its embolization. So the incidence rate in those patients with tissue valve is lesser than mechanical valves. Next, please. So we have a target INR when we do valve surgery, especially for example, if you have mitral valve repair, but still, if your patients have atrial fibrillation, you didn't put mechanical or bioprosthetic valve, you have only a ring, which is easily covered by our own immune cells in the first 6 months. But if you have atrial fibrillation, it is better to cover them with warfarin, and the target INR is only 2.0 to 3.0. But for patients with mechanical valve replacement in the mitral position, the target INR is from 2.5 to 3.5. While for patients with aortic valve, with mechanical valve, the target INR is from 2.0 up to 3.0. Next slide, please. So the reason for the lower target INR for aortic position is because hemodynamically aortic position is more active or hemodynamically active than the mitral position, and it is less thrombogenic in the aortic side than that of the mitral position. Next slide, please. So sometimes your patient might come with more than INR. As I have told you, there is a target INR. If your patients come with hemorrhage bleeding more than INR 5, then it is better to stop warfarin. And sometimes if your patient is bleeding, it's better to start with FFP and subsequently follow the INR. And when your INR comes down, you reinitiate the warfarin with small dose and you subsequently come up with 20% increment per week. Next slide, please. The other major complications that you see after valve surgery is what we call stuck valve. Sometimes your patient, after having valve replacement, you will see that they have their valve is blocked. And if it is a mechanical valve, if the surgery was very recent, like it is in the last 1 year, within 1 year, the reason for your stuck valve might be either technical or it might be because of an active fresh clot, which is hampering for opening and closing of the valve leaflets. In such conditions, you have to consider active medical treatment with either oral anticoagulant or can be by with streptokinase, whatever you have to have medical treatment first and then subsequently. If all this management fails, you can go for surgery. But if the surgery has been more than 1 year, it might be because of a pus growing into the valve leaflet and hampering the leaflet motion, especially in the hinge point. So in such condition, again, it's always better to give the chance for medical management, especially if your TE gives you a good evidence that there is a clot in the LA or in the leaflets. It is always better to give them a medical treatment first. Then if the medical treatment fails and patient is deteriorating, then surgery will be the curative option. So the other is warfarin in pregnancy, which is a major thing. Patients have valve replacement and they will come to you that I want to get pregnant. What shall I do? So as I have told you, there are multiple publications throughout the world that patients who are taking warfarin, especially 5 milligram and less, the chance of having warfarin embryopathy was said to be almost nil. So patients can continue with their warfarin and continue with their pregnancy, but it should be under the close follow-up of the cardiologist and the gynecologist. But those patients who are taking warfarin more than 5 milligram, it is always advisable to stop warfarin. It is more or less, it is not really finished in this, the argument is not finished, but it is nowadays almost the consensus is reached that the patient should stop when it plans to have pregnancy, taking more than 5 milligram, should stop warfarin before the conception. And then once the pregnancies have been confirmed with urine and ultrasound, then warfarin should be stopped for the first 3 months. And after the first 3 months, patients should continue with heparin injection. We will put them with heparin for the first 3 months, but it is really expensive and most of the patients didn't afford to buy this heparin injection for 3 months. So this is the issue that we are facing in our situation. And most of the patients, they just continue with their warfarin and they will not take heparin. But those patients who can afford the heparin for the first 6 months, the first 3 months, they will take heparin. Then after the first 3 months, once organogenesis is over, then we will again reinitiate them with warfarin, and warfarin will continue for the course of pregnancy until the 9th month. At the end of 8th month, we again stop warfarin and put them again on heparin for the last 1 month, and patient will deliver. The mode of delivery that is most of the time advisable is as much as possible to make it short, a kind of procedure with a short, terminating the pregnancy with a very short delivery process, which is cesarean section, is most of the time advisable, especially inducing them, putting them on induction and putting them for long labor time might be very dangerous. Next slide, please. The other disastrous and dangerous condition that you don't want to see after you do valve surgery is prostatic valve endocarditis, which is an infection that occurs on the prostatic valves that you put. And really, it is very devastating. And the most important thing is early detection and early treatment. And if a medical treatment controls it, it's fine. But if patient deteriorates, early intervention of surgical intervention, by surgical intervening and removing the source of infection is the most important thing. But it is one of the most disastrous complications that you see. Next slide, please. Yes, usually, if you have a prostatic valve endocarditis infection in the first 1 year, it is always better to think of that the source of infection is your surgery. But if it occurs after 1 year, the source of infection might be elsewhere. It can be from pneumonia, or it can be from UTI elsewhere in the body infections. Next slide, please. The final complication is periprostatic leakage. This is why that you need to have a cardiologist evaluating your valve replacement. So after valve replacement, you should have patients should be evaluated nicely for any kind of periprostatic leakage, which shouldn't be there. Nowadays, it's almost it's obsolete because of a proper stitch technique and a good refined stitch materials. Nowadays, almost periprostatic leakage is almost not hard most of the time. But if it occurs, it needs intervention as early as possible. Especially patients are highly vulnerable for infective endocarditis when you have periprostatic leakage. Next, I think that's all I have. Thank you very much for your attention. And that's all I have for you. And any questions, any kind of doubts, now you can forward it and we can discuss it.
Thank you very much, Dr. Fekede. That was a very informative and immersive session. So you've managed to cover the surgical approach to valve replacement in rheumatic heart disease. You've provided us with personal anecdotes that have served to further elaborate the practical points you were making. So once again, thank you for that. Having said that, we'll directly proceed to the Q&A. My co-host, Dr. Asrafil, will share his screen and he'll read out the questions to you and we can go back and forth. Thank you.
Hello, everyone. First, we'll start from the questions in the question and answer box and we'll further continue. I'll try to share my screen as well. Bear with me a little bit as I'm having trouble with that. I'm trying to share the Word document which I have gathered the questions on. For a starter, we can start with the first question till I do so. The first question reads, do we give long-term anticoagulation after valve repair for severe mitral stenosis or only 6 months suffice? Is there a need to extend beyond the 6 months is the question, I think.
Yeah, this is a good question. If the patient that you have done mitral valve repair for severe mitral valve stenosis have a normal sinus rhythm, as I have told you, based on what you did on the valve. For example, it's uncommon to put ring for patients with valve repair for severe MS because what you may do is commissurotomy bilaterally, mobilization of the chordae and the papillary muscles. Otherwise, it's because it's already severe MS and putting ring, be it partial or complete, is not logical. So in such situation, you may not have any foreign substance. Even you may not go giving warfarin them for 6 months because if they are in sinus rhythm, you didn't put any ring or foreign substance, you don't need to even go for 6 months. You might stop it even after a few weeks. You can stop the warfarin and patient might continue with the other treatment. But if you put a ring, the thought is that 6 months is enough for the ring to be epithelialized with own cells. So after 6 months, you can stop warfarin if the patient is sinus rhythm. Now, as I have told you, if the patient is sinus, still there are some risk factors like giant, huge LA. If you didn't do LA reduction in appendage removal, if you have severe LV dysfunction, if a patient has history of stroke, all these are really strong predictors for recurrent thrombus formation in those conditions based on patient-to-patient variable. You have to decide based on the patient situation. But the classic teaching is that if you have ring, 6 months is enough if patient is sinus rhythm. But if the patient is not in sinus rhythm, if the patient has atrial fibrillation, even for the patient that you put, ring with mitral valve repair, warfarin should stay for life.
Okay, thank you, doctor. The second question reads, indications for surgery in asymptomatic elderly person with asymptomatic degenerative aortic regurgitation.
If the patient is asymptomatic, especially for aortic valve lesion, and if it is degenerative one, I expect that it is AS. How come this? I mean, if patient is aortic stenotic, caused by degenerative lesion, is usually causes aortic stenosis. If patient is asymptomatic, there is no need for to go for surgery. But if at all you have to go for surgery because of aortic stenosis, because of degenerative lesion, and if patient is above 65 years, it is better to put the tissue valve in the aortic position. And if a patient is not sinus written, and if a patient has atrial fibrillation, in that situation, I think you have to again keep the patient on warfarin for life.
Okay, thank you. The third question reads, to elaborate on the approach to bleeding or embolism while on warfarin for mechanical valve patients.
Yes, as I have told you, if your patient, for example, comes with hemorrhagic complication after you do CT or MRI, and it shows that there is hemorrhagic lesion, and the first thing that you do is that do the INR. If it is supratherapeutic, then you have to stop warfarin. Then you have to keep as much as possible, give them FFP, and if patient is continuously bleeding from like nasal bleeding or whatever it is, you will give vitamin K, and after that you will bring it down to the normal or subtherapeutic level. Then after that you will reinitiate the warfarin after patient's INR, the level of INR comes to the therapeutic or subtherapeutic level. But during that process, as I have told you, you have to give them FFP and vitamin K for the bleeding complication and to bring down the INR.
The fourth question reads, why is there no rejection for bioprosthesis if it is really truly xenograft?
It is treated, the tissue valve is treated with glutaraldehyde. Even it is coming with this immersed or embedded with this glutaraldehyde 6%. So this glutaraldehyde treatment of the leaflets that are being taken from porcine or bovine, it is totally, the natural tissues are totally, the cross linkage has been totally destroyed, and the epitopes of the protein are not there to elicit this inflammatory process. That is the reason that they don't want rejection of the tissue valves.
Okay, thank you, doctor. The next question reads, what is the possible cause for failure of prostatic valve before their anticipated time?
Yeah, there are different reasons, as I have told you. The most important reason for this valve can be structural or it can be non-structural. So, for example, if you have a pannus growing into the valve, it is not structural. Okay, if thrombus is formed and thrombus is closing the valve, it's not structural. If LV is not working, if a patient has all the reason to form clots, then this is not structural. But when you say structural, for example, tissue valve can have a heavy calcification on its valve after, if the patient is especially growing one, metabolically active, high calcium turnover, they have a likelihood of calcifying of the leaflets that you have seen in the pictures. And this is called structural or degenerative lesion. The same is true for the mechanical valves. Once they have served years and years, it is not uncommon to see that the valves sometimes to degenerate by their own, even if there is no functional issue with the heart or the ventricles or any thrombus or pannus formation. So before their time, it is usually because of non-structural, as I have told you. Either it is because of pannus growing into the tissue, into the valve, or because of growth formation, or sometimes even technically the way you put it. For example, In the mitral position, we say that there is a strict rule how to put the valves, and you have to how you cut tissues so that they will not interfere with the leaflet motions. So even technical issues are there for valves to have failed before their planned time.
The next question is, what is the place of rivaroxaban in postoperative patients?
There is no place for rivaroxaban in structural valve lesions. The place of rivaroxaban for atrial fibrillation is for lone atrial fibrillation without a structural lesion. When there is a structural lesion, it is warfarin, and it is clear and cut, and the research have shown that it shouldn't be tried for patients with structural lesions.
The next question is endocarditis a contraindication for surgery?
Yeah, it is clearly stated in the presentation that infective endocarditis is not a contraindication. The debate is when to operate it. As you have seen it from the presentation, there is emergency taking like in the first 24 hours, urgent in the first 1 week, and delayed when you have controlled the infection and take it. And that is dictated by the patient's presentation and the clinical scenario that you have seen. For example, if you have a highly mobile vegetation, which you might think that might go to the brain and end up with massive stroke, you have to take an urgent decision to take the patient. And if patients are having end-organ deterioration like raising renal function and patient's hemodynamic status are not holding, then urgent and emergent decisions are necessary. But if patient's clinical situation is mild despite the diagnosis clear-cut, if a patient's hemodynamics are stable, you can give you better give time for controlling the infection for some 2 weeks and take the surgery after preparing everything for the surgery.
Excuse me. What is the plan in the near future for the expansion of cardiac surgery in our setup?
This is actually a big question, which needs multidisciplinary team involvement and answer. So maybe it's better to ask such questions for the policymakers. But as a citizen, what I just wish is that to expand first one of the best cardiac center in the country, which is the Cardiac Center of Ethiopia, make it center of excellence, take fellows for cardiac surgery, train them, and distribute them throughout the country in all directions. And then these guys who are going in the 4 direction should have their own role in establishing cardiac surgery setup in Gondar, Makale, Redwa, Wellega, and so on and so on. So I think the first thing is to help cardiac center to have, or Black Lion Hospital to have cardiac surgery training setup. In that way, first you stimulate people, fellows who are training surgery to join cardiac surgery, train them, and have an ample professionals, and then dispersing this training in the all throughout the country, and then that will be, I think, the way to initiate cardiac surgery program in the 4 directions of the country. It shouldn't be only in Addis Ababa. It should be, the service should be available in all directions. To do that, first we have to have a good center where you can train and distribute professionals. That's what I think.
Okay, thank you, doctor. The next question is, what is the risk of rebound valve thrombosis if one discontinues warfarin, and with how many days is thrombosis considered to issue?
That is one of the questions that I gave to you in this quiz. So the most important thing for patients with rheumatic heart disease after cardiac surgery is discipline. When you say discipline, they should be stick to the follow-up. They should be stick to the life pattern change. they should take all their medication. They should have a regular disciplined follow-up to the hospital. They should, the dietary management, the lifestyle change, they should accept that and they have to live with that rules. If they don't do that, and especially those patients who are taking warfarin, and if they discontinued warfarin, we have seen a lot of lives being lost just for discontinuing taking warfarin. They didn't understand what it is really doing. And even sometimes some of the patients will leave it for a week, and then after a week or 2 weeks, they will take it like, oh, I didn't take for 1 week, okay, I will take more, and they will take a lot of pills, and that will end up with a massive complication, with hemorrhagic complications. We have seen many patients ending up like that. So I think awareness creation lessons for each patient who underwent cardiac surgery, training nurses to teach patients on who have surgery for valve surgery is really very important for them to stick to the discipline.
Thank you. The next question is, what is the risk of thrombosis with IV vitamin K for patients with supratherapeutic INR?
Yes, I really don't like to give vitamin K for patients who have valve replacement coming with supratherapeutic INR. I usually prefer to give FFP, fresh frozen plasma, and better to give time. And usually vitamin K is just for bleeding purpose. So patients who come with bleeding nasally or bleeding excessively. But in my limited experience, I don't like to give vitamin K. Rather, FFP will usually control, will lower the INR, and the bleeding should be tackled by the other means of stopping bleeding. And once the INR comes down, the bleeding by itself will stop. But when you give vitamin K for patients, especially with mechanical valve, there is a risk of thrombosis of the valves that you have put, and that is a killer. You see, you want to treat something minor which is bleeding. You can't give it time. You can't stop it with some other means. But when you give vitamin K, sometimes you may end up with thrombosis of your valve, and you might lose your patient. Usually, I just prefer to use FFP when it is supratherapy.
Okay, thank you, doctor. The next question is antibiotic prophylaxis for rheumatic fever needed after valve repair or surgery? And if it is indicated, for how long should the patients be on antibiotic prophylaxis?
There is no such indication. There is no indication at all. There is no indication at all. But as I have told you, patients with rheumatic heart disease who have for example, if you have mitral valve replacement, still you might have the chance for aortic valve, rheumatic process, tricuspid valve, pulmonary. So you have to continue. There is a World Heart Federation criteria for this prophylactic benzathine penicillin, especially for those who are having continuous this rheumatic fever. Those patients should continue for life. But those patients who doesn't have those processes, especially more than 2 years, if you don't have the rheumatic fever, the tonsillar infection is not there, usually you might stop it after 40 years. But if the rheumatic process is there, if you have active tonsillar infection repeatedly, better to continue it for life. That is because you have replaced one valve, but still you have another valve. And if you have repaired the valve again, the valve is there, you just repair it. So the prophylaxis rheumatic process should continue. That is a logic, okay?
Okay, thank you. The other question is, after bioprosthesis, which if degeneration happened, what is the possible management?
Yeah, we have already discussed that in the redo section of our presentation. We have discussed that in patients with a classic degeneration of tissue or mechanical valve, as I have told you, if it is degenerative valve, surgery is the only option, especially in tissue valve. There is no option other than surgery. You just go for surgery. But for mechanical valve, if it is closed by clot, or if it is the clot, there is still I mean, clot can be the cause for the subtherapeutic warfarin might be the cause for clot formation. So in that case, you have a medical management option, but in tissue valve degenerated and you have severe stenosis or severe regurgitation, the option is surgery only.
Okay, thank you. We only have few questions left, and the next question is, when should we stop heparin preoperatively?
Usually, especially for pregnant ladies, when we stop warfarin and put them on warfarin, start them heparin, you have to stop heparin 6 hours before the planned surgery. For whatever reason, you put them on heparin 6 hours before surgery, you can't stop it. This is just to decrease the bleeding risk when you open the chest.
The next question is, can valve surgery, any type, reduce the risk of infective endocarditis post-op in the future? If so, how much is it with the same?
Yes, I think this part also we have discussed it during our prostatic valve endocarditis. So as I have told you, it is a devastating complication that you don't want to see. And if it occurs in the first 1 year, the microorganisms might reach the valve during your surgery. But if it is after 1 year, as I have told you, the infection might came from somewhere else in the body infection. The incidence rate is very low, it's less than 1%, but if it occurs, as I have told you, aggressive early detection and aggressive antibiotic treatment is a mainstay of treatment.
Okay, thank you, doctor. I think the remaining questions, all of them can be summarized in one, and some of our attendees are asking if there is any plan to expand to other regions to reduce the waiting time for patients, and also to reduce the cost. I think all can be answered simultaneously.
Yeah, I have already shared my view how we can reach out throughout the nation. So I think that is my thoughts, but I think this is not up to me as to how to proceed with this problem. But as I have told you, cardiac surgery shouldn't remain as a luxury, especially patients with rheumatic heart disease are really very poor, and they should have the chance to access it in the setup where they are. That's all I have. Thank you.
Okay, thank you, doctor. Dear attendees, now we will be sharing the quiz link here as well, and also on the Telegram group. After a few minutes, we will return with doctor to redo the quiz questions once again. We would like to thank Dr. Fekede Agwar for making time from his busy schedule to hold this session with us. We're very much grateful. Doctor, if you could stay with us a little bit until our attendees do the quiz, and we'll return to you shortly.
5 minutes, please. Thank you.
Okay.
So thank you very much, Dr. Israfil. Thank you very much once again, Dr. Fekede. You've addressed all the questions in a patient manner. So we'll share the quiz link here as well as on our Telegram group. Today's quiz link is a bit different. Instead of multiple choice questions, all of the questions are in a true or false format. There are approximately 20 questions. So you will have 20 minutes to attempt the questions. So I am sharing the link here. I've shared the link here on the chat box, and I've also shared the link on our Telegram channel. You have 20 minutes to attempt the quiz, and after that we'll recuperate and attempt them together with Dr. Fekede. Thank you.
Yes, I can see.
Okay, so in order to make it easier for our attendees to attempt them, as we've talked earlier, we've made it into a true or false format. So the first question reads, there is consensus as to the optimal timing of early surgery in patients of rheumatic valvular heart disease complicated with infective endocarditis.
Yes, it is false. Yes, there is no time consensus. It is just the clinical condition of the patient that guides us. Okay, we have discussed it. Okay.
Thank you. The second question reads, delaying cardiac surgery for 6 weeks after stroke occurrence may lead to significantly reduced likelihood of post-operative stroke.
True. Yes, we have said this is
Thank
after.
The third question reads, it is better where possible to postpone open heart surgery in a pregnant woman until after delivery.
True.
Okay. The fourth question reads, atrial fibrillation in chronic rheumatic valvular heart disease is a class 1 indication for open surgery.
False. Okay, it's not a class 1 indication. It's not an indication by itself.
Okay, thank you. The fifth question reads, patients with severe mitral stenosis with persistent left atrial thrombus benefit better from surgery than from percutaneous intervention.
True.
Thank you. The sixth question reads, asymptomatic patients with severe mitral regurgitation and preserved left ventricular sizes are candidates for surgery.
True, yes.
Okay.
Mitral valve repair. These are mainly for valve repair.
Thank you.
Such patients.
The seventh question reads, mitral valve repair is the best option in children and reproductive age women, irrespective of valve anatomy.
False. Irrespective of valve anatomy. The most important factor is anatomy, not the age or the reproductive age.
Thank you. The eighth question reads, transesophageal echocardiography has paramount role during mitral valve repair in the operative room.
True. Without TE, it is better not to try mitral valve repair.
Thank you. The next question reads, whenever aortic valve is severely insufficient, it should be repaired as it has an excellent outcome in durability.
False. Clear false.
Thank you. Organic tricuspid valve involvement should be addressed during left side heart surgery.
True.
Thank you. The 11th question reads, mechanical valve replacement for children coming from remote areas is the best long-term option.
False. Because the
you.
remote area, children will not have a good control for INR. So it's better to avoid warfarin in such patients, and repair is usually the best option.
Thank you. The 12th question reads, mechanical valve replacement is the option in old age above 65.
False, yes. This is tissue valve, yes?
Yes. Okay, thank you. The 13th question reads, whenever available, tissue valve is superior to mechanical valve in age less than 30 years.
False.
The 14th question reads, women in reproductive age affected with chronic rheumatic valvular heart disease and atrial fibrillation can be advised to have tissue valve replacement.
This is false, yes? Because it is fibrillation.
Okay, thank you. Let me go back. So the 15th question reads, mechanical valve has the advantage of low target INR as compared to tissue valves.
False.
The 16th question reads, disciplined lifelong follow-up is the key for better long-term outcome.
True. That's what we discussed.
Okay, the 17th surgery. The 17th question reads,
prostatic valve endocarditis.
okay, is the first year of surgery is likely to be acquired during surgery.
True.
Thank you. The 18th question reads, stuck valve is a grave complication following mechanical valve replacement, which needs urgent detection and intervention.
True. Patient prosthetic mismatch. Patient, this one I didn't discuss it nicely, but patient prosthetic mismatch. When patients gain excessive weight after valve surgery, there will be a situation called patient prosthetic mismatch, PPM.
Okay, so patient prosthetic mismatch is when patient outgrows the valve and left ventricle struggles to fulfill body demand.
Yeah.
Okay. The last question reads, target INR for mitral valve replacement by mechanical valve is from 2.5 to 3.5.
True.
So okay, these are all the questions. So on behalf of Yetena Weg and our attendees, I would like to thank Dr. Fekede for taking his time out of his busy schedule to give us this very informative and immersive session. It is an honor and a privilege to learn from you. So once again, thank you. And to everyone that has attended, thank you for joining us. We have another session coming up next week, same time. Closely follow our social media in order to get notifications. So once again, thank you, Dr. Fekede. Good night.
Thank you very much, everyone, for giving me the chance. Thank you. Good night.